The Curbsiders Teach podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions.
Furthermore, the views and statements expressed on this podcast are solely those of the speakers and should not be interpreted to reflect the official policy or position of any entity. You should always do your homework and give us any feedback.
Welcome back to the Curbsiders Teach Season 5, our series for health professions educators. I'm Dr. Molly Hoybline, joined by my co-host, Dr. Ira Krzyzewskaja. On today's episode, we discuss best practices for leading morbidity and mortality conferences with Dr. John Erickson and Dr. Matt Clark. Before we get started with that, Ira, will you remind the audience what we do on this show?
Of course, Molly. We are the Health Professions podcast for all things education. We use expert interviews to bring you teaching pearls and practice-changing knowledge to inspire the next generation of clinician educators. And we have a fantastic conversation with our guests, Dr. John Erickson and Dr. Matt Clark. We talk about leading morbidity and mortality conferences, also known as M&Ms, best practices for those, kind of the various acts that go into an M&M conference, and really just tons of pearls around making the most effective and also safe psychologically M&M.
Dr. John Erickson is a hospitalist at Maine Medical Center. He went to medical school at George Washington University School of Medicine, completed residency at the Strong Memorial Hospital. He was the associate program director for the Maine Medical Center Internal Medicine Residency. His academic interests include bedside teaching and strategies to facilitate learning along the continuum of an individual's career. He was pivotal in the development of the hospitalist track and developed the coaching program, and continues to help with supervision of the Morbidity and Mortality Conference Series for medical residents.
And Dr. Matthew Clark, DO, is a hospitalist at Maine Medical Center, Portland, and he is also an associate program director for the Internal Medicine Residency. His interests include medical education, leadership in medicine, and exploring uncertainty in medicine. He finds joy working with residents on the wards, in the classroom, and of course, prepping for M&Ms. He is proud and humbled to be a part of the journey of the residents' journey towards realizing their own why in medicine.
We are excited to bring you this season of Curbsiders Teach with the support of and in partnership with the Alliance for Academic Internal Medicine. And a reminder that most of our episodes are available for CME credit through VCU Health CE for all health professionals at curbsiders.vcuhealth.org. Thank you to all of our Patreon members. If you love the Curbsiders family content and haven't yet joined, please consider supporting us and continuing to create this amazing resource. So without further ado, let's get to it. Well, we are so happy to get to sit down with both of you today. Dr. Erickson, are you okay if we call you John today for this recording?
Please.
Wonderful. Would you like to share just a little bit about yourself? We'll read your professional bio, but if you want to share some things from outside of medicine, just so we can get to know you a little bit better.
Yeah, that's great. Well, I'm from Massachusetts originally, but have been a long time Mainer, and I'm sort of what I guess I would say a 70-ish. So we'll leave that as it is. Internist who really had a career-long interest in education. I had the joy of being associate program director at Maine Medical Center for a long time, and governor of the Maine ACP. I'm the proud father of 3 kids. My oldest is a family medicine doc in Portland here. And I've got grandfather to 2 grand boys, which are our great joy. As I used to say during our intro sections when we did our residency candidate interviews, I love being on the water, but not in the water in Maine. So those are my highlights. Yeah.
Does on the water mean like in a boat, John, or like in a, like in a plane above the water?
Yeah.
How close are we to the water?
Yeah, a few inches is usually pretty good for me. Yeah, I haven't been that much high above the water before, I don't think. Yeah, a few inches is good.
That's awesome. Well, thank you so much, John. And Dr. Clark, is it okay if we call you Matt?
Absolutely.
Wonderful. Well, thanks for being on the show with us, Matt. Do you mind also sharing a one-liner, including something not in medicine about yourself?
Sure. So I grew up in New York. I, too, am an adopted Mainer. And I would describe myself as an early career physician, an educator, an APD for the IM program, who finds a lot of joy working with trainees at all levels, taking care of patients directly. And outside of the hospital, I have a 6-year-old and a 3-year-old that keep me very busy, but make me laugh every day. And I fancy myself an amateur cook of Italian food. And I guess I would describe myself as someone who really enjoys being immersed in a new experience. So that could be in a book or a movie or a TV show. And I think that's the best way to describe myself.
Amazing. And that leads us right into, do you have a recent book or movie or TV show that you really enjoyed, something you want to share?
Sure. So this is a little nerdy, and there will be some nerdy things sprinkled out throughout the podcast, I'm sure. But over the holidays, I got into the Red Rising series. It's science fiction. It's by Pierce Brown, I believe, is the author. And it's kind of like, the way I would describe it is kind of like a mature Hunger Games meets Dune, but without the sandworms and without the spice. And the author is like a political scientist, so it deals with a lot of things like human psychology and forms of government and political science, and has some really interesting characters. So I recommend.
Yeah, I've never seen any of those yet.
There's still time.
Yeah.
It's a growth opportunity, John. Don't worry.
You can be inspired by this.
That's what it's all about. Absolutely,
Yes.
growth.
You can engage in them while on a boat above the water.
That's right.
That's right.
Yes. Well, thanks for that, Matt. For you, John, is there also a book or movie or show or album, music-wise, that you've recently enjoyed?
Yeah, for an excuse to exercise, I've been watching Wolf Hall on PBS and the Passport, which is fascinating, about Cromwell and so forth, which is just an amazing series. And a couple of months ago, finished reading Doris Kearns Goodwin's book, No Ordinary Times, which is a remarkable story about Eleanor and Franklin Roosevelt, and sort of behind the scenes look at a power couple who had great separation, but incredible synergism in so many ways that were so important, and kind of respectful use of power that is something that's a pleasure to read about in these uncertain times.
It's a great way of putting it.
Yeah, well, thank you for sharing those. In light of our focus on the Morbidity and Mortality conferences today, I was hoping that one of you or both of you might be comfortable sharing a time in your career when you were involved in a medical error, and just briefly sort of what you learned from that and how you reflect on that.
Right. Maybe I'll start with
Sure.
just a short one, Matt. I think the one that sticks with me, and I think this is sort of emblematic of the way we work with our residents, is to think about the things that sort of eat at you and that you remember sort of often. And this was later in my career, not that I did not have issues early in my career, but is most memorable. There's a probably 80-ish-year-old woman I'd taken care of for a long time who had alcohol use disorder and hypertension, hyperlipidemia, was a smoker. She was hospitalized for complicated gallstone pancreatitis, and I think she underwent an ERCP, and then before she was discharged, had a cholecystectomy and went to skilled care for a period of time. And part of the evaluation unearthed the fact that she had actually probably a 5-centimeter AAA. And I didn't actually end up seeing her before she was re-hospitalized a couple months later with a ruptured AAA, and it was fatal. She died. And sort of that, in looking back of it, I was thinking, well, gee, she was known to the vascular surgeons, maybe they should have followed up on it. And then thinking, well, gee, she had a lot of comorbidities that could have gotten in the way of her undergoing surgery. But sort of the bottom line is that I didn't provide her with the information, or her family with the information that allowed her to make a sort of informed decision. And there were some assumptions that were made there. And I think that recognition of as physicians, I think particularly as general internists, it's really incumbent on us to make sure that our patients and their families are well informed, and that they're the ones that are involved in making the decisions rather than us. And so I think it allowed me to sort of turn down the assumption dial a bit and accept more responsibility myself. But I still think about that. Yeah.
It's really beautiful, John.
Yeah.
Thanks for sharing.
Yeah, thank you for sharing that. It's hard. I mean, we all struggle with no one's ever perfect all the time. And in primary care or as an internist or wherever you work, there is just so much information and so many details to make sure we're passing on correctly to our patients. And it can be tough. I mean, I just saw someone last week where she had an abnormal lab result from like 6 months ago that probably was impacting some of what was happening with her health. And I was like, how did no one follow up on this? Why did no one in the hospital tell her about this? And then I looked back at my last note and I had actually copied and pasted it into my note, but just not actually registered it as something to follow up on. And it's hard. Things do slip through.
And we make so many cognitive shortcuts along the way. Like this is not connected to their current presentation, or like the AAA has nothing to do with the gallstone pancreatitis, and we're managing this acute thing. And it's really easy to get kind of caught up in those cognitive shortcuts that we make and also reason our way out of it. Matt, I wonder if you are comfortable sharing also kind of an example or a time in your career where you were involved with an error and what you learned.
This goes back to my training and really early in my training as an intern. And I think about this often. One of my first times on the wards, working with a senior resident, and I hadn't had a lot of experience with admissions. And, the senior resident was like, oh, we got an admission. She kind of pumped me up for it and said, Matt, you're going to go down, do this admission. You're really going to focus on the med rec. This is your first real med rec. And I remember going down and the patient was coming from a long-term care facility and had a lot of medical problems. And she had a really long medication list that came to us in the form of a MAR from the facility that she lived at. And I remember interviewing the patient and talking to the family and sitting down and going through the med rec. And it took me a long time as a new intern to sort through that and put it into our EMR the right way. And I thought I'd done a really good job with it and felt good about it. And I went home and the next day after sign out, the senior resident pulled me aside and said, hey, I just wanted to give you some feedback that there was a mistake in your med rec. And she kind of showed me what happened. And she said, nothing happened to the patient. I caught the mistake and this is what happened. But I just wanted you to know. And she used it as a real opportunity to teach me about med rec. And I still think about the things that she said to me that day, even now as an attending. And I think about it when I work with trainees and I pass forward the things that she taught me. And when I take a step back, I think about sort of the aftermath of that. And I was kind of like beating myself as an intern. You can imagine, like really hard on myself about that. And she pulled me aside. She noticed that. And she kind of debriefed it with me again. And I learned 3 things that I still bring forward when I work with trainees. She taught me to give myself grace. She modeled for me that whatever the problem is or whatever the issue is, if it's beating someone up, it's important and not to trivialize anything. And she really taught me and modeled for me growth mindset. Like this, we all make mistakes. It's what we do in response to that. That's really important. I think about that a lot.
Well, those are really lovely lessons to take home from that. And I think it's a perfect segue into our discussion today around the morbidity and mortality conferences. They do have a long history in medicine, dating back to 1910 when Dr. Ernest Codman, a surgeon, became focused on tracing the end results of surgical operations. The early conferences were mostly focused on surgeons and anesthesiologists and focused on medical errors in order to improve surgical practice. But over the years, M&Ms have played a major role in many training programs, including as an ACGME requirement for some residencies. So with all that in mind, let's focus on a case from our fictional hospital, Cashlek Memorial. We have Gabriella. She's a new chief resident preparing for her first M&M. She remembers learning a lot from the M&M conferences that she attended in residency, and she's eager to teach and moderate her first one. However, she's also quite nervous. She's not sure of the best structure for an M&M or even how to go about selecting a case. She asks you, her APD, for guidance to prepare the M&M and tips to create a safe learning environment while delivering the case details. So that's a lot to dive into. So to help her on this journey, could you share how you see the kind of overarching purpose and benefit of the M&M conferences? And maybe to make it a little more concrete, maybe a specific example of an M&M that you attended that really stuck with you because either of the interesting case or the systems changes that occurred afterward.
Yeah, thanks for that question. And I would tell Gabriella that she's asking good questions and the right questions. But I'm going to start with a little bit of a nerdy metaphor, if that's okay, to answer the part about what is the purpose of M&M. So think about Star Wars, original trilogy. Think about Empire Strikes Back. So to set the scene, Luke Skywalker's now without a teacher. Obi-Wan is dead. And he wants to seek out a teacher. So he goes to find Master Yoda. He goes to the swamp planet in the Dagobah system. And he goes there and he finds them, he's training and they're running and they're practicing the Force and doing their Jedi skills. But he sunk his ship into the swamp and he can't use the Force to lift it out. So Yoda says, "You're not ready to be a Jedi." And he says, "I know what you need. You need to go to the cave." And this gets back to Plato and all these things. But he brings him to this cave and he says, "I can only go in so far with you. And you have to face whatever's in this cave," right? So they go in together, and then Luke goes on his own, and he faced Darth Vader and his fears and all these things. And he comes out, and he's a different person. And he's able to lift the spaceship out of the swamp. He has a better mastery of the Force. He's ready to be a Jedi. And like for me, that's what the M&M experience is about. So the residents start this journey. They have an M&M prep week, and they go into their cave. And I can only go so far with them. And they come out and they give this beautiful presentation where they're celebrated for their vulnerability, where they teach their colleagues and the faculty and the institutional leaders something useful to leave the presentation with. And when they do that, to me, that's like the ultimate capstone. That means they're ready to be an attending. And for me, that's what M&M is really about. And if we as educators can prepare our learners for the hard things that are going to come up and keep showing up throughout their careers, then I think that's a real win. And that's what it's about for me. And thinking about a particular example, there's so many. And if you ask any of the people that I work with every day on the wards, there's not often a day where I don't reference an M&M that I've either saw as a trainee or participated in as a faculty member or helped the residents through. But if I had to pick one, I think back to the first M&M as sort of like the faculty lead for the M&M experience that I participated in. And the crux of the case, the clinical details are not so important, but essentially it was a really challenging case for everybody involved. So for the staff, for the residents, for the attendings, and for the patient. And the resident presented this case, went through the case, did her teaching points, and it had this really beautiful moment about 3/4 of the way through the presentation where she just opened up and was super vulnerable about why this case has stuck with her for years, and was super vulnerable about how it sort of haunted her through the years, and how it stuck with her. And then this sort of organic thing happened where everybody in the audience, so faculty members and other residents, started, either they were familiar with the case and had participated, or they had a sort of similar case experience, and they kind of shared, they opened up and they were vulnerable too, and she was a model for them. And I think about that a lot because it's really emblematic of something. I listened to podcasts by Brene Brown. She's like a shame researcher, and she says something, I'm paraphrasing at this point, something like shame just needs 3 things to grow. And it's like secrecy, silence, and judgment. And the antidote to those is empathy. And there was just so much empathy in that room in that moment. I just can't stop thinking about that. And we all left, faculty, residents, the presenter, we all left with the resolve to do something about that. And so what came of that, we embedded sort of these clinical debriefs into our academic half day with our psychiatry colleagues, so the senior residents can come and talk about a challenging case. We built a new morning conference series with the help of John, where the residents can bring a case that stuck with them and they can't stop thinking about, so they can share it with their colleagues. And really what this crystallizes that the hardest things in our training is the times where we struggle through something alone. And these are sort of opportunities for them to not be alone. And I'm really proud of the work that the residents did and the program did and the institution did to support that change based on that M&M.
Yeah. Wow, Matt, I and also John, I definitely want to hear an M&M that stuck with you as well, but I want to just reflect or kind of highlight something that resonated with me, which is this idea of the cave, which I really wish that somebody had, gave me that Empire Strikes Back anecdote when I was preparing M&Ms as a chief resident, because it would have totally changed my mindset. So thank you for that. But I think there's like a cave connection, because Brene Brown talks about like what empathy actually is, which is to get into the cave with somebody. Like if they're in a dark hole and things are looking bleak, it's not compassion where you're like yelling down at them being like, hope everything's okay down there. It's like getting actually into the cave. And I think there's something beautiful in those two kind of cave metaphors or connections, because you can only go so far with somebody in the M&M cave. Like they have to at some point kind of create the case or kind of think about the conference on their own, but there is this kind of support walking alongside them in this dark and scary and vulnerable and kind of really can be painful time. So I think it's really an interesting imagery that you brought up, and kind of like where the light comes in and kind of their production of this M&M conference. But don't want to take away from John, because I can see you're on the edge of your seat to share your M&M memory.
Yeah, no, I'm actually, that's really beautiful. I think a beautiful image of what our experience here is about. I mean, I was just sort of thinking about, we were sort of talking about sort of shame and sort of that's being really, I sort of think of being the sub rosa message that oftentimes has sort of lined all of our careers, and hopefully, I think our road is really to change that. But I was sharing with Matt this morning. There's in one of my feeds came across from JAMA Internal Medicine, a really, really good opinion piece that I would very strongly encourage our listeners to read. It's written by an advanced endoscopic gastroenterologist at the Medical University of South Carolina. His name is Joseph L. Munzer, and the title of his piece is First Do No Harm, a career-long struggle with iatrogenesis. And it's fascinating. And what he says that I think sort of crystallizes at least a significant part of it, if I can quote it. At the end of the day, we're all human, and even when we practice medicine perfectly, complications can and will occur. This is a fundamental challenge of being a healthcare professional. As I continue to grapple with this reality and wait for better solutions, I try to keep sight of the only conclusion I've ever reached on iatrogenesis. I can execute a perfect procedure, but complications still happen. In this profession of uncertainty, the only thing I control with 100% confidence is how kindly I treat patients and how hard I try to help them. This is the only thing that's helped me feel better about complications. And I think that I would extend that by saying, I think what we see as being so important is the ability to share that with each other. And hopefully that ripple effect allows us to be better physicians, not only for our patients, but for each other.
That sounds like a really special culture that you have there, and sounds like you've really built a lot of psychological safety around the whole team being comfortable sharing, even around the same case or different similar cases, which is amazing, and I think something for us all to aspire to. Do you have any tips or any thoughts about how you created that culture or how that culture formed, how to support that in other settings?
Yeah, I think it's a significant amount of modeling. I think we believe in it. The department believes in it. As faculty and leaders, we believe in it. And so it's something that we model as well as share. We believe very much in being sort of preemptive and proactive. One of the things we've talked about a little bit is how do you deal with the challenges that come up in an M&M. And I think I'm sure you've see these where somebody puts up their hand and says something that can be difficult. And I think for people that are thinking about designing M&Ms, one thing that we would say is if you can be proactive and anticipate what might happen, it's hugely beneficial for the resident. And I think concomitantly it's beneficial for the group because they see, oh, gee, this is how we do this. And so we always stress at the beginning of our M&Ms that, as you said, medicine is hard, and there's a huge amount of uncertainty. And in the moments that we have to make decisions, which are oftentimes fleeting, we have to put a lot of uncertainty and very little data together to do things. And sometimes it's a procedure, sometimes it's commission, sometimes it's decision not to do things. And so I think understanding that we all do our best when we're doing that, and again, I think it's this sort of opinion piece says, as you mentioned, that along the way, regardless of how good we are, we're going to make mistakes and things are going to happen that are untoward. And so I think creating that understanding up front that we respect everybody for this, and that rarely is it one person's decision or action that leads to problems. It's really almost always sort of, we talk about the Swiss cheese model of error and so forth. And so we emphasize that as what's going on.
I also feel like there's some component of like meta iatrogenesis in the sense that, when creating an M&M or preparing for it, which we'll dive into in a second, but even during the M&M, there are ways that we can create iatrogenesis for the people who are there and the people who participated. And y'all have really done work to proactive work, it sounds like, to ensure that that doesn't happen. But if we take a step back and we're kind of like hearing Gabriella's concerns and how she needs to be proactive, but also she needs to prepare. And, there are a lot of steps that might go into kind of how to best kind of create this M&M conference. Can we kind of hear from the two experts in the room around what you all do relative to who you invite? How do you kind of think about the case and the structure of the actual participants in the case, separate from, maybe a checklist for the actual M&M conference itself?
That's good. I'll start with that, and then Matt will maybe go into the details of the week itself, which I think is really important. In our thinking about this, and I think looking at the reason to have a conference is, there's several different layers, and I think there's the presenter themselves, there's the audience that's present, and then there's really the systems, and then sort of surrounding all of that is the benefit to patients over time. And I think our conference series, our M&M conference series specifically, puts the third-year resident at the core. And so our feeling is that the greatest impact should be experienced and by that third-year resident. And everybody in our residency program, the Med-Peds program, as an R3 does this M&M. So everybody in the residency in their tenure will do this. So our feeling is that that experience is one that everybody experiences. And so,
can I also, John, sorry to interrupt
please,
you. Can I also highlight how novel that is? Because I think residencies across the country, it's not always the R3, the senior resident. It's often the chief residents. I mean, even a decade ago when I was doing this, and we joked about the PTSD that came with this. There was so much preparation involved by the chief resident. And it doesn't mean that the actual resident involved in the case was not doing preparation. Like, we were working with them, we were supporting them, we were ensuring we were carefully and honestly presenting the data as they saw it. But it is very unique, I think, to do the model that you are suggesting for all residents to go through this experience and to really have it be like their own. So I just wanted to highlight that I do think that is relatively novel. I'm sure there's probably many programs who are doing that, but I will say that a large majority are also doing it where it's not the residents involved who are really creating this and putting it forward.
Yeah, it's sort of it's a capstone project for us, and it's sort of folded in at some level with your QI, and there's a number of different layers to doing it, but it really is sort of a capstone project during their residency. And so they're at the core. They are the ones that we put the most emphasis on. Sort of a sphere surrounding that is the audience, and basically our audience is fellow residents, the faculty in the department, the leadership of the department. Always present is basically representatives from risk management, because they're involved with our process as well. Oftentimes our ethicists or somebody from the ethics department accompanies us as well. And then we have basically, it's an open conference. We don't invite patients and families for a variety of different reasons. But we also do try to make sure that we identify either people that have been involved with the case, or if there's departments, let's say it was a case that occurred in the ICU, we want to make sure that we have an intensivist involved that will represent that department. Because our hope is that in hearing this, they'll see somewhere where some of the issues, particularly system issues, come up, and they'll be able to take that back and work on it. And, we sort of work with the residents in advance and in the first meeting that we have with them and say, who are the stakeholders? Who do you think would like to have there? Who was involved with the case? And then we really walk through the challenges that there might be for different individuals. We know that there are certainly personalities of people that will wax eloquent, and we talk about how to manage that. We also talk about people that may be suffering from the impact of the case themselves and how to sensitively deal with that. And so then it's really up to the resident to invite. It's really they send out the invitations by email to specific people that would otherwise not necessarily attend. But we think that concentric sphere, the residents at the center, the audience, and then beyond that is the hope that there's some impact from a system standpoint. Although, as much as we would like that to happen regularly, that's probably the least impact that we see system-wide, unfortunately.
Yeah. And I would say part and parcel with the resident sort of at the center of the sphere, I think it's really important that they know who's in the audience, who to expect in the audience. And I agree with John. It's really important to give them the autonomy and empower them to invite their own attendees. And, coming out of COVID, we thought a lot about like Zoom and how we present that with M&M. And we actually made the decision this year to sort of eliminate the Zoom option for the M&M because we found we got feedback from the residents that it was really hard to have like people on Zoom and then have this sort of like faceless voice kind of chime in at some point. And that was sort of like antithetical to like the safe culture that we were hoping to achieve in the conference itself. So I'd say it all comes back to the resident, giving them the control of their presentation.
Absolutely. Yeah. And it really is their case. They choose the case themselves. And it is, as you said, it's the things that sort of stick in your mind that Matt remembers from his internship. And I have particular memory of this older patient with a AAA. So those are the cases that I think tend to be most impactful. Back in the days of yore, it used to be driven by the autopsies that were done. And, with autopsy rates being probably less than 5% in most institutions, that's not a big driver. So we look for things that have a personal and professional importance to the resident, and then work on focusing on what they see as the major issues along that. Yeah.
And is there a particular framework or checklist that maybe when residents start on this rotation or kind of part of the preparation outside of, selecting the case, it sounds like choosing who to invite, having that be very kind of autonomously driven or resident driven? Are there other things that are kind of on their to-do list potentially as it revolves around the M&M?
Yeah. And this gets to a little bit of like the structure of the conference itself as well. And I would say the journey through the M&M experience, it starts with a dedicated M&M prep week in their third year, usually early in the year. And there's sort of a balance between sort of prescriptive content and structure that we give for them. And then we also, but we want to balance that with sort of like the latitude to make the experience what they want to make it. And so really that experience starts with them meeting with me, in the past, John, and bringing the case or cases that they've been thinking about. And we dedicate an hour, set that aside, and chat about the cases. And after they tell me in their own words, sort of like what the case is about and sort of their takeaways from the case, I ask them, I say, what were the harms here? And I challenge them to think beyond just the patient. So there's harms to the patient, harm to the family. And then in the second tier, there's harm to them, the physicians and the nurses and the therapists and everyone involved. And then there's harms to the system and the institution and the system writ large. And so I ask them and solicit sort of their gut responses to that. And I say, okay, so in the context of your case and in the context of this self-identified harms here, the things that you see as the harms, what are 3 or 4 discussion points, major focuses for your presentation? And these are things sort of like discrete topics that they will present during the presentation. And hopefully each one will leave the audience with something tangible to leave the presentation with. And I usually tell them it's really helpful if one is really like clinically focused, sort of like a clinical pearl, and they can present some data, query the literature. And then the other 2 are more like process and systems and maybe specific to our institution and policy driven, things like that. And so we kind of brainstorm that, and based on the discussion points and the harms and the story, we kind of go through a list of who the stakeholders should be. And that's really the exercise of our initial meeting. And there's sort of like these constitutive faculty sort of experts that everybody meets with. So like everybody meets with our vice chair of quality safety. Everybody meets with the director of patient safety and risk management. And then if it's a clinic case, they'll meet with like the director of that clinic, or if it's something that happened in the CICU, they'll meet with the cardiology service line lead. And after we identify the stakeholders, we coach them to reach out to stakeholders, set meetings, and we realize that all that can't happen in 1 week. And that's why it's a journey. But I do tell them during their week, what I want them to do is to really think about a timeline. And I challenge them to think about a timeline and the scope of their clinical narrative, right? So some cases are really macroscopic. So clinic-based cases often are over the course of years, but then some are really microscopic. So a night in the ICU and sort of precipitous events. And so I challenge them to think about the scope of their clinical narrative and then build a really detailed presentation timeline in PowerPoint. And as they go through their meetings and with their stakeholders and they refine their sort of discussion points and sort of develop that, they can sort of edit and refine their timeline. And by the time their presentation comes, it's really streamlined. And so we have a smattering of readings and things like that they work on during the week. In the past, some IHI modules and things like that they work on. So kind of like a balance between structure and sort of choose their own adventure. But that's the crux of the M&M experience. And then I would say,
And Matt, sorry, just to interrupt for 1 second. Apparently I'm on interrupting game, so sorry about that. But when we just had an episode where we talked about kind of goals and objectives and creating those. And I do want to highlight for the listeners, it sounds like your discussion points, you're actually prompting residents to create their kind of goals and objectives for the M&M conference. And even though their clinics, some might be clinically focused, some might be kind of harms or QI focused, you're still really asking people to generate those kind of learning objectives, maybe not naming them as such, but essentially their goals and objectives up front and kind of, working to flesh out via the timeline and the PowerPoint, kind of those learning objectives for how will the learners be able to achieve XYZ by the end of the M&M. Does that sound right?
That's exactly right. So it starts with the patient story and then really framing their learning objectives or discussion points. Exactly right.
It really is I think that dynamic is sort of reflecting on it from a learner perspective, really looking at this being a way of them teaching too. I mean, this is really an important way of them developing a very meaningful teaching tool. And so I think that exactly. I think some of this stuff, like the diagnostic error, there's a litany of diagnostic error that oftentimes the framework hangs off of. And that's something they've done. I mean, they'll do in their conferences on their academic half days, they'll address these things, but they'll be able to put a name to it relative to their specific case, which I think is oftentimes, as Matt's oftentimes will say, spaced repetition is a very good thing. Yeah.
Well, that sounds like an amazing rotation or week-long block that you've created for your residents. Are there, I'm sure it varies based on the case and each individual resident, but would you say there are kind of main goals around QI and around working with risk of sort of what the residents should take home from that and what they should carry forward as the resident who's actually involved in making the case?
Yeah. Sometimes they meet with risk during their week. Sometimes it's after the week, depending on the availability of the people involved. And I would say every case is kind of unique and different, but oftentimes the cases that the residents are bringing are cases that have been digested elsewhere. And what I mean by that is there's probably oftentimes like an institutional RCA that's been done already. So if it hasn't been done and there's going to be one that's happening, that's something, an objective for the resident to be involved in. But if it's already been done and there's already been an effector limb based on that RCA, I think hearing from risk, I think that would be one of the objectives we would expect from the residents to kind of bring that forward in their presentation and say, like, there was an RCA and this was the outcome of that. I would say that that's a useful part of their experience with risk. But I also find that the residents tell me that their experience with the risk people and sort of the other constitutive faculty members that they meet with, I think it we kind of go in with our discussion points, but it prompts them to think about things in a different way. So everybody has their own perspective on the case. And what I love about our M&Ms, if you had 3 residents doing the same case, you'll probably get 3 totally different M&Ms. I really love that about our M&Ms. And so in talking to the vice chair of quality and safety and talking to the risk management folks and reviewing the case with them, you kind of get their take on it and their perspective on it. And I think that's really valuable for the residents.
And sort of in parallel to that too, there's been times where residents have talked about sort of similar cases in similar venues. And there's a reason for that. If there's an area that there's a real issue, then it's not harmful for that to be heard more than once, particularly from a system standpoint. If that does happen, we definitely emphasize that it needs to be different. The presentation has to be different. And I was just thinking your comment about RCAs, if they've been done before, I don't think I can ever remember sort of residents saying, well, this is what they said at the RCA. They really are very invested in their own perspectives, filtering that through. Mm-hmm. So I think they really recognize this as being their own scholarly and professional endeavor and not just a regurgitation of what other folks have done.
I agree with that, John. Yeah. I agree with that.
And to your point, John, I feel like even if there is repetition, like maybe this case was discussed in a previous or a different setting, there's something beautiful about the spaced repetition, about revisiting something. Absolutely. And revisiting either a different learning objective or a potentially even a same one, but really kind of highlighting it in a different setting potentially. And what I really love about this episode and what you all are doing is kind of pulling back the curtain on something, on a conference and a kind of institution, we'll say, the institution of the M&M, so that people really understand like the components of it, what goes into it. And it's not just kind of something that's being presented to them and kind of thrust upon them, but something where they're an agent kind of creating it and they're through the learning experience themselves kind of really driving it. I think that's not only does learning stick more, I mean, we've had an episode on the science of learning that we've referenced probably a gajillion times, but it really does, when you're in the middle of it, it's a totally different experience of solidifying that knowledge. And I wonder, I mean, you mentioned RCAs, you've mentioned other structures. Are there QI tools or other, maybe we haven't said the matrix model yet, but are there other things that residents are being taught with kind of meetings with you all or on this rotation that really helps them create kind of an excellent M&M presentation?
Mm-hmm. Yeah, we've been advised that we should use the matrix. I'm assuming you're suggesting the one that comes from Vanderbilt and built on the competencies. And we are required by our GMA department to do that. We probably favor and feel that a more powerful tool from a planning and a structure conference standpoint, and frankly, from a teaching standpoint, is actually the fishbone. I mean, the fishbone really, I think, as Matt said, sort of taking those harms, putting them together, and where did they come from? It's really, that's by far, from my perspective, a far more powerful tool than trying to slot stuff in boxes that never seem to fit quite right.
Yeah. And also just from a purely practical standpoint, right, the fishbone looks a lot slicker in a presentation, in my opinion.
And we've had some very fine fish.
Yes, that's right.
Our residents are very clever as far as finding very interesting fish and bones to present. Yeah.
Yes. And the fishbone, I tell the residents, there's no way that they're going to present every issue for most cases that they're bringing. Like, these are very complicated cases. And it's okay. Really, it's okay to focus on the three things that we talked about or that they think are important. And really, their time is limited. This is an hour-long conference. And in reality, they only really have 40 minutes of content time. And so we do a lot of coaching on that. But the fishbone is a really nice way. It's a nice concluding or beginning a concluding sequence for the presentation. And it can summarize the things that they've went through during a presentation, so driving home learning points, but then it can also highlight other things that may have been a factor that we didn't have time to really unpack in a deep way during the presentation.
The other thing I just want to mention too is that the conference is very interactive. I mean, I used to say, plan on 35 minutes of prepared material because it's going to span into 40, and then we really need to be 15 or 20 minutes for conversation. And we coach our residents about what questions you want to ask, what things you want to toss out to the audience to reflect on, and then sort of after they've had that discussion, which takes a bit of time to get started, and then once they get going, it's hard to slow it down. But once they've gone through that, then you show your own ideas on a slide so people can reflect on your reflections and so forth. There's really nice networking that occurs during the session because of the interactive nature.
Yeah, so early on when I meet with them during the first week, I'll talk to them about like presenter efficiency. And what I mean by that is For anyone to stand up there for 45 minutes and just talk, that's really hard on everybody in the room, so the audience and the presenter. And so I tell them, be kind to yourself. Let's think about these sliding door moments. Let's think about your discussion points in the clinical narrative, and really think about ways we can embed questions to engage the audience. And as it gets closer to the presentation, they fleshed all that out. We'll do kind of like a one-on-one sort of mock M&M. So I'll sit down with them. We'll go to the boardroom or wherever their M&M is going to be, and they'll kind of tell me the point of each slide and then practice their sort of engagement questions. And I always tell them this is not a morning report, right? Like we're not putting the audience in the hot seat. We're not quizzing their medical knowledge. We're not doing the Socratic method here. It's more about giving them the opportunity to share their perspectives as it relates to the case and the discussion point that they're presenting. So coaching the resident about framing those discussion points.
And do you have some coaching pearls that you like to run through with the residents about how to, you were talking earlier about being proactively prepared to sort of diffuse situations if there's kind of some more pointed questions asked that may put people on edge, or help kind of diffuse some of that feeling of shame or sadness if some people in the audience are more expressing that? How do you kind of coach the resident through that?
Yeah, it's a great question, Molly. This is where I think actually the facilitator comes in. I think we sort of make them aware that this can happen. It's surprisingly infrequent, I think, that it actually does happen. But I think some residents are very able and interested and capable of dealing with that. But I will also say that we feel pretty comfortable with, stepping in ourselves and saying, let's and we'll redirect basically at that point, and it doesn't go beyond that, and so I would say that oftentimes it involves redirection by the facilitator, though it really is their show. There are times where we lurk. We're there with a microphone, and we're very comfortable with saying, yeah, let's move on to something else, or let's move to this other question. So I realize that maybe avoids the specific training that we might do with residents around that, but the harder places are places that we feel the facilitator is within full power to sort of step in.
And we'll tell the residents that, we'll tell them, we're there, we got your back. This is your show, this is your presentation, but we got your back if you need us. And I would say this is a very rare, I would say 99% of the time, it's not necessary, because I think, and that just speaks to sort of the culture over time that John and we've built in this conference. But in thinking about the discussion questions, I'll ask them when they propose sort of the question that they're going to engage the audience with. I'll say well, what do you think they're going to say? And hopefully, like John said, the goal would be to kind of underscore the points that they're going to make a little bit later, and then they can summarize that. But I'm always asking them, always challenging them to think about, okay, you're going to ask this question, what do you think the response is going to be? So all that anticipatory guidance.
Absolutely.
I love that, because I feel like in some ways y'all are, again, this is like the meta M&M. Y'all are asking them to think through the possibilities and kind of almost M&M their M&M. What happens if it doesn't go as planned? It's not just the dose of the beta blocker. It's what if the dose of the question isn't, it doesn't land correctly? And so what, or as you intended, not correctly, but what do you do in those settings? And I kind of love that essentially practice kind of thinking about what happens, or what do they do when that happens? I wonder, are there other pearls that y'all have, or that you talk to residents about saying, hey, you said your discussion points that you wanted to talk about were X, Y, Z. How are we going to really kind of, put those home for folks at the end to really make sure that you got what you wanted across in this M&M? Are there things, around lessons learned that you really try to highlight for residents as they kind of prepare the summary component of the M&M?
Yeah, I would say the third act of most resident M&Ms is sort of a wrap up. And I would say most times it starts with the fishbone. So again, that's kind of an opportunity to drive home. These are the discussion points we made. This is where we're at with these issues in this case as it relates to this case. And here's other things that contributed to this outcome that we didn't have time to unpack. So that's sort of that's part one of the third act. Part two is typically an effort yield plot. And so we asked the residents to imagine if they could go back in time and implement an intervention that could have maybe changed the outcome here, what would those be and how hard would that be? And so we asked them, what would be the effort here? And then what would be the yield as it relates to the outcome of the case from their perception? And there's no real right or wrong answer there. But I find that that's a really nice way to sort of summarize some of the issues and give a little bit of optimism and hope about what are the next steps, and really start a discussion about the effector limb of the M&M presentation, right? Like maybe we should start a complex case conference, and what would that look like? And then the audience will often engage on these things and people will brainstorm organically and everyone leaves with a little bit of buy-in, which is really cool. And then the other parts of the third act sometimes include like a cost of hospitalization, which sometimes is relevant, sometimes is not. And we asked the residents to kind of summarize from their own personal experience what their takeaways, like if they were going to impart something to their learners in the future, what are their takeaways from this experience as a whole? So the case and the experience, and kind of their last words of wisdom, which I think is really effective and resonates, especially with the other residents.
And Matt and John, just to highlight, you gave us a really nice kind of anatomy of the third act, the wrap up. Can you just remind the listeners really quick about Act 1 and 2, and making
Definitely.
sure that if we skipped over those, that we didn't skip over those, or that we kind of really, for spiral learning, came back to them again and really reemphasized?
Yeah. So Act 1 is like setting the scene, setting the foreground. So it's who they are, setting the culture. So John did before me, and I'll usually introduce the resident and make a little statement, say, quote Walt Whitman and say, this is about curiosity and not judgment, and kind of set the stage. The resident will introduce themselves and they'll set the scene for their case, who the patient is. Usually they'll kind of be a little vulnerable in that moment and give a little preamble as to why this case is stuck with them, and gives a little flavor of where the M&M is going. And that's also a time to introduce some of the themes that will kind of like recur throughout the presentation. And then it's really setting the clinical stage. So that's where this like concept of macro or micro setting kind of comes into play. So they'll kind of say, we're in the ICU on this night and I'm the intern. So really putting the audience in the shoes of the primary team. And usually in our case, that resident was the primary team in some form. And then Act 2 is really the core of the presentation. So that's the clinical narrative as it unfolds. So the timeline that they've built from their first week, and then all the discussion points that they've been working so hard over the last several months to develop with their stakeholders, and then embedding in those discussion points. So that's really the bulk of it. And like we said before, for those first two acts, they really only have 35 to 40 minutes. So I always tell the residents, make sure that there's a clock within your line of view, or you're in presenter mode and you can see the little clock in PowerPoint. Because if there's only 10 minutes left, wherever you are, whatever discussion, we're going to have to move it along. And if you need help, one of us will help you. But most times they don't need our help. And that's like a touchstone to get to the fishbone, get to the fishbone and wrap up so you can do your Act 3.
Thank you. That was a beautiful summary. And then you had mentioned kind of all of these ideas that can come out of, how we can move forward from the lessons learned or things that can be improved upon. Do you have any formal mechanism to ensure that those actually happen, that those great ideas don't just get lost after the M&M?
This is really the challenge, and I think it sort of addresses how we make this more system wide with its changes. And interesting sort of historically, and I have to give a nod to Matt as being a former chief resident here, but this being built on the shoulders of some erstwhile chief residents, I think particularly Nick Fox and Nick Dupuy. Nick Fox is a intensivist in South Carolina, and Nick Dupuy is one of our stellar hospitalists here. So in the past, basically, we had something called the Resident Quality Forum, which grew out of one of the survey programs that was on the ACGME survey program. And so there was a Resident Quality Forum that was, I think, a representative from each of the residencies and the administrative physician that was in charge of that as well. And they would present basically these cases. That was one of the requirements initially. That sort of dissolved over time. The intention was that they were to, by presenting that forum, it was to be kicked upstairs to those that could make the change. Unfortunately, it didn't happen. And to be very honest, I think probably even nowadays, if the resident has fire in their belly about a certain issue, then they will go with it. If they're glad they did it, but they're also glad it's over and it's near the end of the year, quite frankly, it might not happen. Our hope is, again, partly by having people that represent the different venues for care, particularly it's the clinic or intensive care unit or the hospital service or whatever, that our hope is that this goes back at the level where there can be change made beyond just the residency. There are clearly things that happen within the residency. I mean, and Matt can probably address some of those things that have happened that have come out of M&Ms that say, this is something we can change. Did any of this come to your mind?
Yeah, so like the example from the top was programmatic change to incorporate meaningful debrief periods for the residents. That's a really salient example. Right now, we're having a conversation about, so we used to have these complex case series, and then like many things that kind of dissolved during COVID. And so we had a really brilliant M&M just a few weeks ago about the phenotype of the M&M was essentially a rare diagnosis and diagnostic uncertainty. And one of the effort yields for that was sort of restarting those complex cases. And so we're having a discussion at the department level about what that would look like. And I guess what I would say is, like, we're not super prescriptive in our program about, like, this is the action item, it's assigned to person X. Like, that's not what we do in our M&M. But it's not uncommon, and that's why it's really important to preserve that time in the third act to digest the effort yield and allow time for audience comments and questions, because that's really where, like, the secret sauce kind of happens. So it's and what's important there is making sure that we have the right stakeholders in the room. And that gets back to the very first meeting where we're coaching the residents to choose the right people to talk to and invite to their presentation. And so it's not uncommon that somebody will present something in their effort yield and the right person is there and they'll say, hey, that's a simple change that we can do. I'll do that. And they kind of self-volunteer. So we're not prescriptive about it, but it's not uncommon for people to kind of step up and say, this is something we can tackle. And I would really just think about some of the bigger things, some of the bigger changes that have happened as, like, in my mind, M&M is just like kind of the start of a discussion that's ongoing for a lot of these issues. And so whether that's in our, like, program meetings or department meetings or bigger institution meetings, I'd really frame a lot of these as sort of the beginning of a discussion. And maybe it's the end of the residents' involvement. Maybe it's not if they have fire in their belly about this issue and they're going to be around. But it is a sort of a faculty level ongoing discussion and start of a discussion.
I also wonder if maybe the M&M, like having such a resident-led, resident-developed M&M, was itself like kind of a product of a previous M&M. Like maybe there was a time in which the M&Ms were really, as they are in some institutions or what I experienced, like really chief resident run. And maybe, at some point in Maine, the sun shined and they were like, well, this should be resident run. And that's kind of how that came up. So I could see that also as kind of a product and an incredible innovation. But I feel like we've had such an amazing conversation around M&Ms. Molly, are there, any questions before we move on to summarization, take-home points?
No, I think we'd love to hear some take-home points. This has just been such great wisdom from you both and inspiring to hear how you've been doing it in your program.
Well, let me lay out a few things, but Matt's the more eloquent of the two of us. So I think the first thing I would tell Gabriella is to decide where the focus of the conference is. And again, our choice has been the resident, but you could make, I think, very good arguments for saying, well, this is really about the audience, or it's really about the systems, and we really want to make a difference for our systems. So I think making an intentional choice around that before you initiate your conference is really a good thing, because I think having that focus allows you to craft it in a way. We've crafted ours that seems to best fit what our focus is, but that would not work for all, I don't think. So I think making that specific decision is really important. I think as far as our perspective is, I think providing autonomy to the resident as really a very senior learner at this point, and really transitioning to being an attending. That's the beauty of being, or whether they're doing a fellowship or not, they're transitioning to another level where they're level of responsibility changes, and recognizing that sort of embedded in what we do is the fact that there are going to be mistakes that we're involved with, and we need to grow with them, and we need to support the growth of others. And so I think that is absolutely critical. And so I think providing them with that autonomy, but also I think under a watchful eye or arm's length or whatever you choose to talk about metaphorically is important as well. So I think you really do need to have somebody that's there to support them through this, because I think that does make it a more powerful experience. I think some of the things we've talked about, laying the groundwork for the residents up front, sort of helping them, as Matt says, anticipate what questions might come up, the challenges that may come from the audience, their own responses to it emotionally, and how they're going to deal with vulnerability in that situation. When you're sitting in a room one-on-one, it's much easier to do that than when you're out in a bigger setting. And so I think that's really the beauty of that first meeting that we have with the residents. We absolutely see that the aegis for this is creating and maintaining a culture of growth and safety. I mean, we absolutely say we're not all just touchy-feely about this. We really do care about patient safety, and we do care about looking at error, and we do care about understanding those errors, and we do care about doing better, but also looking at this as being collaboratively coming up with ideas as how we can do that. And so that cultural nurturance is important. And then, as we said, just if it's possible to work with the department or with the hospital or the clinic administration to make change with this is really the other piece that is sort of, I guess I would say, is more aspirational at this point than practical. But I think it's worthwhile keeping that on the list of how can we get to that next level. That I would see as being an added, not a bonus, but I would see it as being an aspirational goal as well. Matt, do you have other thoughts?
No, that was really well said, John. And I would just go back to what I said at the beginning, like if you can think about the cave and build an experience for the residents where they come out on the other side and they're maybe a little bit different, and they have the building blocks to deal with something that's really hard later in their career, then that's a win. And we'll get in the rink with you, and we'll be there with you. But a lot of that work's going to come from them.
Or on the East Coast, West Coast, on the parquet, as we say.
Yes.
Amazing. Well, do you, either of you have any resources you'd like to plug? Things that you're working on, recent publications of yourself or mentees, or just resources that you found really helpful around M&Ms?
I would really encourage people to read that article that I spoke of earlier. I think it's great, and we can make sure that that's shared with you.
Yeah, we'll definitely link that in our show notes.
Yeah, there's a list of other references that I think are really useful. Great. Yeah, there's the Systems Approach to Morbidity and Mortality Conference from 2010 in the American Journal of Medicine. I think reflects an approach that is, I don't think I wasn't aware of, but I think we organically grew something that was very similar, but I think has a nice outline as to that. Yeah. Other thoughts, Matt?
Yeah, I agree completely.
Amazing.
Well, thank you so much.
Thank you both.
Well, Ira, that was such a wonderful conversation we had with Dr. Erickson and Dr. Clark. Do you have some take-homes that you are planning to try next time you're helping with an M&M conference?
Yes. I mean, I think big picture, Molly, I love the idea that every resident is involved in creating kind of an M&M, thinking about a case that was really powerful for them, and then walking through the kind of acts of the M&M that Matt told us about. And I think one of the things I'm going to try and do is kind of talk to our residency team around what's the possibility of having every single resident go through this experience and to really share kind of the lessons they learned and create this psychological safety and just go through the educational experience of creating an M&M. I think that's very powerful. So that's one of my take homes. Molly, what about you?
Yeah, I will second all of those. I think those were amazing pearls. And I was just really struck by the culture that they have created there at Maine Medical Center and sort of the culture around their M&M, and really, they get so much out of creating the conference and thinking about QI and thinking about long-term structural improvement. But really, for me, what seemed like the crux of what the residents take home from it is a safe space to be able to debrief about a case that's really stuck with them or made them feel, uncomfortable or unsettled. So I think giving our learners the space to be able to open up about those challenging or cases that have sort of stuck with them was a really beautiful inspiration.
Totally. I'm with you.
This has been another episode of The Curbsiders Teach. Get your show notes at thecurbsiders.com/teach. A special thanks to the Alliance for Academic Internal Medicine for helping make this season possible. And thanks to Dr. Matt Watto and Dr. Paul Williams for their support in this project. Thanks to Dr. Karishma Patel for behind-the-scenes work and writing up the script for this episode. Thanks to the team at Podpace for editing and production support. Until next time, I've been Dr. Molly Hoybline.
And we're committed to providing you with high-value, practice-changing knowledge. And to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts or contact us at thecurbsidersteach@gmail.com. A reminder that this and most episodes are available for CME credit for all healthcare professionals at curbsiders.vcuhealth.org. All you have to do is create an account. I'm Dr. Ira Krzyzanowska. Thank you for joining us today and letting us bring you a little nugget of medical edutainment.